Assalamu alaikum. I'm just trying to make these small, short videos related to certain anesthesia concerns. So I will be just starting with some concerns related to ENT surgeries. Okay. Generally speaking, any surgery in which your access to the airway or access to the patient is limited will be considered as a risk factor for some of the complications, like especially if you have this oral surgery like tonsillectomy, or any facial-maxillary. I'm barring out facial-maxillary surgery. I'm focusing on ENT surgeries and adenidectomies or paranasal sinus surgeries, okay, like FES and everything. So the general concern will be that you will have shared airway and limited access to the patient. Patient will be covered, so the tube dislodgement and if you have any problem, this will be a big issue. And if sometimes when they are pulling, stretching the area, maybe tube can come out. Okay, so this is one of the most important thing you should be considering. Then of course bleeding, there may be both intraoperative bleeding as well as post-operative bleeding. So this should be your priority. You are placing throat pack, so all the concerns related to throat pack, not only the throat pack material, because throat pack material should be soft, because it will be a big source of post-operative sore throat. Okay, so ideally it should be soft material, and it should be soaked with saline as well as, if possible, water-based jelly, because fat-based jelly or anything which is causing crusting will actually increase the incidence of sore throat. So this will be an placement notifying in the nursing chart. Okay, and when it is removed, because there are incidents of retained throat pack, and another opposite is to proceeding with the surgery without placement of throat pack. So concerns related to throat pack, concerns related to tube dislodgement, kinking of the tube. So you need special endotracheal tubes with curved right tube, or if you are doing certain procedures in which they are using the silicone tube, so you have to be knowing about that situation. Then especially in nasal procedures, they are using decongestant, okay, in the form of either this xylometazoline or something like that, or also they are using epinephrine. So sometimes if they are not sure about the dilution, they can inject a lot, and even when they are putting it, the absorption may be different. Okay, so you should be taking care of it, and you know that if it is the standard 1 into 200,000, so you should be knowing that 1 into 2,000 epinephrine is 5 mics per ml. 5 mics per ml of epinephrine. So you should be knowing what concentration they are using, or because if sometimes they are not using that preparation and they are making it themselves, so this will be a dangerous thing, and you should be knowing how much epinephrine they have put in their solution, because otherwise it will be causing absorption of the epinephrine, resulting in tachycardia, and actually this problem will be augmented because they will be asking for hypotensive anesthesia. So hypotensive anesthesia itself will be a challenge for you, that like they are injecting something which is causing actually hypertension, and they are asking you to do controlled hypotension. So with reference to this thing, with reference to hypotensive anesthesia, you should be taking care of it, because if it is a young patient, maybe you don't have any problem, but if you have a patient with some hypertension and anything which can change the cerebral autoregulation for blood flow, you should be taking attention on it. Okay, so whatever the blood pressure, baseline blood pressure is, you have to keep it around to 20% for that, and ideally you should take arterial line, and you have to zero, because sometimes this point is true for even shoulder surgeries. This point is true even for any other surgery in which they are asking hypotensive anesthesia, that if they are making a slight head side up, okay, this will actually decrease the engorgement. Especially this is true for this nasal surgery, that you can request them to raise the head side a little bit, so that that there is decrease in engorgement because of the venous pooling. Okay, so when you are doing it head side up, this will be reduced. This one thing. And then when you are taking arterial line, it is preferable to zero it not at the level of heart, to zero it at the level of external auditory meatus, the tragus, so that whatever blood pressure reading you are getting will indirectly roughly depict the cerebral perfusion pressure. So this is a trick you should do, and you should not zero it at the level of heart, and you can show them the blood pressure. And then there are some other things you can offer, tranexamic acid. And actually, like a number of times they are asking you to create hypotension, and actually the reason is the engorgement. There is some other reason, there is microvascular oozing. So hypertension is not only like they are only looking at the number, and especially if you are not having the intraarterial blood pressure, you can never be sure, because the PP size cuff is sometimes different, and sometimes because in such cases, sometimes especially if you are doing shoulder surgery, they are putting the BP cuff in the foot, in the leg. Okay, so that blood pressure, because one side you have taken IV line, one side they are doing surgery, so anesthesia technician will put the BP cuff in the leg, so that BP will not be reliable, that will be a little higher than the normal one. And so you should not rely. And if at least in exam point of view, you should always say that it is better, whenever you are having a controlled hypotension, you should have arterial line. So this is the baseline. Okay, so coming back to the concerns other than this one, so of course there will be a certain patient age group in which there will be more chances of ENT surgeries, like adenoids will be in pediatric patient, and especially if you have patient with adenoids or kissing tonsils, very enlarged tonsils, there will be a chances of OSA. So you definitely have to rule out OSA. Of course, these patients will not be obese patients, but if you have such consideration, you should rule out presence of OSA. Okay, and then there will be chances of recurrent or respiratory tract infections, and actually a number of cases which we are cancelling because of upper RTI in these patients, actually unfortunately some of the time they are unjustified, because they will never have a time when they don't have any RTI, because they will have a little controlled sort of situation, and you just have to find a window period in which the symptoms are minimum and you can proceed with the surgery. Okay, because a patient who is undergoing the surgery because of recurrent infections, the tonsils are getting engorged and adenoids are getting enlarged and they are creating problem, so you can never get a patient without any symptom. So there will be a little bit of symptoms, and you just have to see whether they are increased in last preceding days, or there is some active infection with like too much productive cough or fever or engorged area, because in that case, even this is not your concern primarily, it is a concern of the surgeon, because if they will be operating in that condition, there will be more chances of postoperative bleeding. So there are a number of strategies to minimize the bleeding. One of them is the cold technique with reference to tonsil surgery. Okay, and they can, because the more they are using cautery, there will be more chances of postoperative bleeding. And in that you should also be knowing about the blood supply of this area. So this, I'm just trying to touch it out, and because if patient rebleed after tonsil surgery, you have to deal it like a patient with shock, second anesthesia, and there will be the blood will be in the stomach, so there will be risk of aspiration. You may be using a one size smaller tube because there may be engorgement of airway, especially in pediatric patients. So these are concerns. You will be dealing it as a patient of shock, and because it will be difficult to estimate the blood loss, so the clinical sign symptoms will be more, because the blood which is inhaled, you cannot quantify it. So the clinical sign symptoms, which are a little different to interpret in pediatric population, but still you have to identify the level of dehydration and level of bleeding, and you will proceed with it. Okay, so I'm just trying to figure out some concerns. And then with reference to ear surgery, the main concern will be that if they are doing anything with reference to tympanic membrane, so nitrous oxide use will be should be avoided, because it can increase the space, especially if they are doing the tympanoplasty repairing. Okay, Then another thing is that this surgery, the ear surgery will, because the area of vestibulocochlear nerve and their vestibular system, this may be involved. There will be high risk for PONV, post-operative nausea vomiting. So you have to take care of something, these things. And actually dexamethasone and granisetron or ondansetron, which we are using in normal patients, actually here you should consider that you are, like, the cause here is vestibular system. So you might need some strong antihistaminic with antiemetic properties, because maybe the other antiemetic will not that much effective in that scenario specifically. Okay, and you have to avoid opioids as possible, or minimize the use, because that will increase the chances of PONV. Okay, then another thing which they are doing it in mastet surgery especially, they are monitoring the facial nerve. So they will be asking you to only have an initial muscle relaxant, and after that they may be using, you might need to use TIVA with you can use inhalational agents, but you will not use any muscle relaxant. You should have neuromuscular stimulation in place, and you can use remifentanil infusion or dexmedetomidine infusion on top of it, and you should not give muscle relaxant. Options will be that you can give an initial dose of rocuronium if you have Sogamadex. If still there, when they have reached that place, you can reverse it, or you can use dexamethasone and then don't give any muscle relaxant according to the scenario. But the basic point is that the muscle relaxant effect should already be waived off when they are doing the surgery. Usually if you are using intubating not a very high dose of rocuronium, half an hour to 40 minutes till the time they actually reach that area, it will already be gone. Okay, but you can do it that after intubation you don't use too much inhalational agent. You can shift directly to propofol infusion or remifentanil infusion, because that will not augment the muscle relaxation as much as inhalational agent will do. Okay, so this is a trick which you can do. They will be doing the nerve monitoring, so they will take a baseline, and from there they will move on. So this is something which you should be knowing with reference to facial nerves. The same concern will be there when they are putting the cochlear implant. So the common surgery which they are doing is either mastectomy or the tympanoplasty, Grommet insertion. Okay, and they may be doing only examination under anesthesia, examination of ear under the anesthesia. So you just have to, the base of all the anesthesia management is that you should have very good communication with the surgeon. Okay, because if you know what the surgeons are doing, it will be better for you to anticipate. Okay, in these patients, they are actually tilting the patient a little one side or other side. The tube should be having some elasticity, or you should leave some space that when they are turning the patient on side, tube does not come out. And another thing is that you should support the neck, because if they are doing a surgery in a specific position post-operatively, the patient will have very, very bad ache in the neck, which is not the surgical area, but that will create a big problem. So you should support it in a way that you minimize this thing. Okay, so just bleeding, bloodless area, hypotensive anesthesia, shared airway, throat pack, chances of CSF rhinuria post-operatively, especially if they are doing FES, there are more chances patients if having repeated infections. You can just have in your mind that this patient may be at risk of rheumatic heart disease or infective endocarditis, but of course you will not do it. And there is another entity which is called as post streptococcal glomerulonephritis. So these patients, some of them actually, my daughter developed post streptococcal glomerulonephritis when she was 4 years old. So that's why I don't forget this thing, because of repeated antibiotics and this infections, respiratory infections. So you should keep in your mind. So this is all about the basic chunk of the things which you will needing when you are doing ENT surgeries. We will have a formal discussion about all this. You can listen to it, and any feedback you can contact me. Thank you very much.